TopMedTalk.
Well, hello and welcome to TopMedTalk. We're here at the annual meeting for the American Association of Nurse Anesthesiology in beautiful, sunny San Diego. I'm Desiree Chappell, co-editor-in-chief and lead anchor of TopMedTalk, and we're here in the exhibit hall on the NorthStar booth. So thank you to NorthStar Anesthesia for providing us space this year at the AANA to do our podcast and talk to some team members here from NorthStar, but as well as leadership within the AANA. And so right now we had the opportunity to catch up with our friend, a fan fave, as I like to say, for TopMedTalk, Dru Riddle, who is the outgoing president of the AANA. Dru, thanks so much for joining us.
Desiree, it's always a pleasure. Thanks for having me. Great to see you again this year.
Yeah, I feel like we kind of have this running thing now. It's like a catch up with Dru. I have all my guest commentators, so thanks for coming back.
Sure.
So Dru, congratulations on your last year.
Thank you.
Of the AANA. But for our listeners, before we dive into that, tell us a little bit more about Dru Riddle.
Sure. Thanks. Yeah. So completing my year as AANA president has been amazing. But in my what I call real job or real life, I'm a practicing CRNA. I actually work for NorthStar Anesthesia.
You're one of the first.
I was one of the, I don't know if we have employee numbers, but I think in the original dozen or two that was hired. I practice in Fort Worth, Texas. That's where I live. My full-time job, though, really is in education. I'm a professor at Texas Christian University, TCU, in our School of Nurse Anesthesia, and I've been there for about 13, 14 years, and love it. Do some research, do some other things outside of the anesthesia space. But
yeah, one of the times we caught up, you told me about your involvement with the Cochrane.
Yes, so I have the pleasure of being the co-chair of the Cochrane U.S. network. So for listeners in the UK, I know you have a large contingency in the UK and elsewhere in Europe. Cochrane is based in London. It is probably the world leader in evidence-based healthcare. So not just a discipline specific like anesthesia, cardiology, et cetera, but really around the production of high-quality systematic reviews that then go on to inform our clinical decisions, guidelines, that kind of thing. And yeah, we have a group in the U.S. There's 20, I'm going to get the number wrong. I think 26 affiliated groups all across the U.S., both in academic centers, healthcare centers, elsewhere that do this kind of work. And I'm privileged to be the co-chair of that group here in the U.S.
Yeah, that's fantastic. Tell us a little bit more about the AANA as a professional organization and what it represents.
Sure. So we are the professional organization, professional society for CRNAs, Certified Registered Nurse Anesthetists in the U.S. So there's just over 64,000 members of the AANA. We have membership that involves mainly practicing nurse anesthetists and our nurse anesthesia residents. Those involved are enrolled in a nurse anesthesia training program. And interesting, actually, next month, we're starting a new membership category for registered nurses who may be interested, perhaps, in nurse anesthesia as a career. And we're going to give them an opportunity. The membership of the AANA voted to change our bylaws to allow them to become members of our organization as well. So we'll be standing up a lot of programming, not just at conferences, but, across the platform to figure out what value can we bring to a practicing registered nurse who may have an interest in the field of nurse anesthesiology. So we're an advocacy group.
Yeah.
We're a standard setting group. We are a social group. We're hopefully all things to our colleagues as CRNAs practicing in the U.S. That's, we are headquartered right outside of Chicago, near the airport at O'Hare. And we have, just like all advocacy groups, we have a fairly large presence in our nation's capital in D.C. as well.
Yeah. Well, Dru, I was telling you before we got started, I'm going to be giving a lecture here coming up in November at the Perioperative Medicine SIG and the Perioperative Summit in Australia, put on by ANSCA and Guy Ledbrook. And I'm super excited about, but the lecture that I'm going to be giving is about the experience of CRNAs and PAs in the U.S. And so I thought I'd kind of start our conversation. If you could explain to our listeners just what is a CRNA? What is it that we do? What role do we play here, kind of in the U.S. specifically?
Yeah, it's a great question. So CRNA, Certified Registered Nurse Anesthetist. So in the U.S. context, there are 4 identified advanced practice roles within the United States. So a lot of folks internationally even are familiar with the nurse practitioner role. That is one of the 4 roles. There's the certified nurse midwife role. There's a clinical nurse specialist role, and then there's our role as certified registered nurse anesthetist. And we are primary providers of anesthesia. We work as part of a perioperative team that may or may not involve a physician anesthesiologist. We work with patients across the lifespan, from neonates or those that are premature, we shouldn't even be born yet, all the way to, into life care. We practice in every setting where anesthesia is administered. So we're in, the typical traditional community hospitals, outpatient surgery centers, pain management, both acute and chronic pain management, obstetrics and gynecology, labor and delivery, outpatient dental offices, and
academic facilities as well.
Absolutely. Academic facilities, CRNAs, for the most part, are involved in direct patient care. There's obviously CRNA scientists. Their entire role is that of conducting research and producing the evidence. There are politicians and there are hospital administrators. A really good friend of mine that I went to CRNA school with is now the CEO of a healthcare system. Nice. And so we're ubiquitously out there.
Yeah.
We used to be called the best kept secret in healthcare because that is no longer. But, a lot of folks don't know or recognize or realize the role and what it is that CRNAs do. Looking, depending on the statistics you look at, but in the United States, approximately 65 to 70% of anesthesia is personally being administered by a nurse anesthetist. So how do you become a CRNA? Well, you are a registered nurse. You must be a registered nurse first. And you must have had ICU nursing experience. So this means someone has gone to nursing school, has obtained that degree and a license to practice, has had on average 2 to 3 years, some more, some less. You have to have at least one of full-time critical care experience. So these are the nurses taking care of the sickest of the sick patients. Then they would apply to a nurse anesthesia program. These are all doctoral programs that are a minimum of 3 years in length that focus exclusively on anesthesia, the science, some of the art that involve both didactic and clinical residency portions. And I think it's important for your listeners to understand that our students, if we want to think of them that way, these are young adults who have between 6 and 8 years of healthcare experience as nursing students and then as practicing nurses before they ever begin to build that foundation of becoming a CRNA. So we're all board certified. We have to be. Yeah. There is not a nurse anesthetist practicing in the United States that is not board certified and then, of course, licensed by our states.
And with the new doctoral program, what does that entail and how is that different than, the master's program that I went through?
Great question. I'm a master's prepared CRNA when I went to school as well as my entry to practice degree. So the additional coursework that is involved in, first of all, not to share my age, but I've been in practice a few years. The science has changed, right? We've learned things. So part of that is there's additional science to know and understand around how, anatomy, physiology, we've discovered new things and how things work. And then some of it is around this idea of how do we critically appraise and look at research and decide whether I should or should not use that perhaps in making a clinical decision for my patient. A little more work on the policy side, understand at a more robust way how health policy works and how can we affect change as clinicians taking care of our patients when we maybe need a regulatory or a legislative something, a fix or a change in a condition there.
I also like the business of anesthesia. I think we're learning a lot more about that. And that's included in our training and preparing us in different ways.
Yeah, that's right. And for sure for your international colleagues, sometimes I actually spend a lot of time in Australia. It's one of my favorite places. And, you talk about the business of healthcare and sometimes eyebrows go up like, what do you mean? In the U.S., our healthcare system is both amazing and broken all at the same time. There's nobody can, I think, argue that. But we do, at the end of the day, we do have to understand the business of what we do. We're providing a service for which we are receiving reimbursement. And that is a business transaction. Whether there's a value proposition on it should or shouldn't be a business transaction in our current environment, it is. And we would be naive to train and produce nurse anesthetists that didn't understand, at least superficially, how that business transaction works. So we try really hard to arm our graduates with that.
Yeah. So CRNAs are in every state.
That's correct.
Here in the U.S. But I think legislation and scope of practice is it's referred to. I kind of don't love that terminology, but like what we can do because with our degree and with our training, how does that differ? Because I think internationally definitely is misunderstood, but even within the U.S., I think there's a little bit of misunderstanding.
Very good point. So yes, we're in every state. We're in all the U.S. territories. We are the primary providers of anesthesia services in all military facilities. So on the Navy, the Air Force, and the Army as well.
Okay.
And our scope of practice, I think you're so right. Our scope of practice is defined at the national level by the AANA. We have a scope of practice that has been laid out and defined by our professional organizations. States, through legislative and regulatory processes on rulemaking, can then decide for the advanced practice nurse, like a CRNA or a nurse practitioner, what will be allowed to happen in that particular state. And so I've practiced in a couple different states, and there is subtle variation state to state. A lot of it has nothing, honestly, to do with the provision of care, the administration of medications and caring for the patient. It really has to do with the regulatory authority, how I get the authority legally to do that in the U.S. And so for international colleagues, we have 50 states and territories, and in order to practice, I have to have a license in the jurisdiction in which I am practicing. So I am licensed in the state of Texas. I'm about an hour and a half from the Oklahoma border. If I were to cross into the state of Oklahoma, I am not legally authorized to practice, even though I didn't dump all of my anesthesia knowledge and skills when I crossed the line. And so there is state to state, some level of state to state variation. Although I will say in 100% of jurisdictions, CRNAs are not required to be supervised by a physician anesthesiologist. So we do work with our anesthesiologist physician colleagues, but we do not necessarily have to or are not mandated to do so, which speaks to an access perspective, right? There's not enough anesthesia providers.
No.
And in jurisdictions or in locales where perhaps a physician anesthesiologist is not located, the anesthesia services may be solely provided by a nurse anesthetist. So,
well, and that's what I was going to ask you about, like, what are the different models of care and what do those kind of look like? I mean, I say when we were talking with Randy earlier yesterday about the models of care for NorthStar, we see everything from CRNA only practice, correct, to physician only practices. So walk us through a little bit about what the spectrum looks like.
Sure. Yeah. And interesting. If listeners are interested, AANA actually has a really nice toolkit that we have produced called the Efficiency Driven Anesthesia Modeling. And this really it's not a recipe book, if you will, but it really lays out, I think, in a really simple and understandable way what these models look like. So you're exactly correct. There are models that are a little bit of everything. There could be a model where, let's use a hospital with eight places where anesthesia needs to happen, wherever those look like. There could be 8 physician anesthesiologists personally providing anesthesia care, one in each of those locations. There could be 8 CRNAs personally providing anesthesia care in one of those 8 locations. There could be a combination of 4 anesthesiologists and 4 CRNAs providing anesthesia care personally. There may be more than 8 individuals where perhaps there's an extra person available to help if there's a complex patient or, just maybe I need to eat some lunch or use the restroom. And it would really be nice to have somebody come in and, I can't leave. I would never, and we cannot leave our patient alone.
Yeah.
And so there's a lot of terms, medical direction, medical supervision. Those get into billing issues, which are kind of a whole nother, that's another hour conversation. But on a day-to-day basis, what we often see is what I think is commonly beginning to be referred to as a collaborative model. And that's a model where we have physician anesthesiologists and certified registered nurse anesthetists working collectively and collaboratively, utilizing everybody's best skill set. And let's face it, there are people that, regardless of your degree, you have expertise.
Sure.
And my expertise may lie in one place and yours somewhere else. And I would always want my patient to have, if you're the guru on placing labor epidurals and I haven't done that in a long time and you're available, why would I not have you do that? Why would I try to, do that for my patient? So, lots and lots of different models. There are some models where CRNAs are restricted in what they have been trained, are board certified, and are within their scope of practice at the state licensure level, but there are facility level restrictions that prevent them from doing certain things. And that's quite frankly, it's a shame because we have highly trained, highly educated, highly competent folks that for some reason are not allowed to do certain things.
Yeah. So I get this question a lot because I tend to be the token, non-physician anesthesiologist in the room at many conversations, but get the question about, what is scope of practice? What can you do versus what a physician anesthesiologist can do? And it doesn't seem that complicated, but sometimes whenever I'm explaining it, it turns complicated. But just for our listeners, tell us a little bit more about that.
Yeah, great. It's a great question. So I would challenge a person who didn't know a whole lot about anesthesia or healthcare in general to watch 10 anesthetics in a row being administered for 1 hour each and differentiate based on the care that was being provided to that patient, who the provider was. If it was a blinded thing, there was this woman there, was that a physician, was that a nurse anesthetist? And I dare say, unless you knew the person, you wouldn't be able to see the difference. What does the scope of practice look like? It does vary state to state, right? Yeah. So while our physician colleagues, because of the way medical practice acts are written, don't have those restrictions, we do. So some people say, well, gosh, CRNAs can't do X, Y, and Z. There may be a restriction on that. Let's use the example of placing a central line. CRNAs can't place central lines. Well, maybe in the facility at which that practice is occurring, there's a reason why CRNAs are prohibited from placing central lines. That does not equate to the global CRNAs can't do that. We're trained, we're licensed, it's within our scope of practice. So if anyone has questions on sort of what can a CRNA do? Can a CRNA put in a regional block?
Yeah.
Can a CRNA take care of a 4-year-old patient? Can a CRNA take care of a complex patient with lots of comorbid conditions like heart disease and diabetes and hypertension? The answer is yes. And I would refer you to our professional association that wrote the scope of practice for CRNAs. That is the playbook, if you will, on what CRNAs are trained to do, are board certified to do, and then look at what is it happening in this location and how much in alignment is that with the nationally accepted scope of practice?
Right.
I hope
that's great. Well, and I think it's really important to understand that we are trained to do all of those things, and that it is just usually a matter of the culture. I think has a lot to do with that, and the site in itself. So I think it's really important distinction.
That's right.
And a lot of people get that confused, about what it is that we can do.
Yeah.
Well, switching gears just a little bit, tell me about this last year. How's it been for you?
It's been fantastic. It's been the professional honor of my lifetime to be the voice in a lot of settings on behalf of us, the collective us, of nurse anesthetists. I've met some amazing people. I've heard some really tragic struggles that have been happening. I've heard of situations where patient care or access to care has been arbitrarily diminished. There's a lot going on in the healthcare space, not just in anesthesia. One of the things I think I didn't really have my head wrapped around as much as I do now, I maybe thought about it a little bit, but surgery and access to surgery is not just life-saving, but it's life-sustaining. But we as CRNAs are involved in so much preventative care as well. So the example I've used and I've articulated to legislators and regulators is, we know the recommendations on getting a screening colonoscopy, for example. Most folks would like to not be awake for that. And, a lot of times when people think anesthesia, they think, oh, it's an emergency surgery. I'm having my gallbladder removed. I broke my leg and I need surgery. I've been in a trauma situation. All of those absolutely are correct. But so much of what we do is life improving. I have this degeneration in my knee and I need this replaced. It's not an emergency if I do that tomorrow, but man, does it change the quality of my life. Or, I'm a healthy, happy 40-something-year-old and it's time to get my colonoscopy and oh my gosh, they found a precancerous polyp and now instead of that developing into some tragic disease. For listeners that are unaware, there's a lot of international statistics around manpower and how anesthesia providers per capita, per 10,000 per 100,000 population, whatever that means. We can train as many amazing surgeons, gastroenterologists, cardiologists as we want, but if we don't have high quality, safe, cost-effective anesthesia, we have a lot of people that need surgical intervention and other kinds of intervention that they just don't get. And it's been really, really fun, because I'm passionate about that, to make sure others that are not in our space understand that.
Understand the need.
Yeah.
What would you say would be the most impact that you feel over the last year that you've had as president?
One of the things I'm most proud of is our collective board of directors. I mean, I'm one voice of 11. There are 11 nurse anesthetists on our AANA board of directors. We are the governing entity of the AANA. One of the things I'm most proud of is the kind of the operationalization and bringing to making it actually happen, that we can open our membership up to individuals who want to join our profession. And that sort of sounds kind of like, oh, look at us, we're internally focusing. But we have to recognize that as a workforce issue, the only way you can become a CRNA is if you are first a registered nurse. And as we said earlier, you have been in the intensive care unit providing. So the pool from which we can draw is reasonably small. And so to build that pipeline much earlier than we have in the past, and I think the board's recognition and focus that we really need to understand who we're trying to recruit into our profession is absolutely critical. So there's a lot of other things I'm really proud of, but as a board, I'm excited and proud that we've been able to make that happen this year.
Yeah, that is really exciting and good news. And, advocating for those people who have an interest.
Sure.
I think it's going to be very, very important in them to have a voice.
Absolutely. Yeah.
They're involved in. That's great. Well, Dru, congratulations.
Thank you.
On what seems to be a great year. You have a couple more days left.
Couple days left.
You hand over the baton.
That's right. Yep. And that's right. And our new president is a very good friend and colleague, Jan Setner, and she's amazing. I think y'all probably have a chance to chat with her as well. And, I'm really excited about the future of our organization.
Yeah, that's great. Well, Dru, thanks again for joining us here on TopMedTalk. It's always a pleasure. Hopefully we can catch up again soon. I know there's always topics that I'm like, I wish I had more time to talk to you. We've had some great conversations over the years about pharmacogenetics.
Yes.
And research and diving into that kind of stuff. So
let's do it again.
Yeah, absolutely. And good luck over the next couple of days. I know you have a crazy schedule, but all right. And thank you for listening to TopMedTalk. If you want to hear more like our conversation with Dru today, please check us out at TopMedTalk.com. We are on your favorite podcatcher. We are also on social media. You can find us there. So thanks so much for listening. Cheers.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.